Good evening, everybody. Greetings from Asian Institute of Gastroenterology. In the continuous series of webinars on COVID and gastroenterology, today we have the 13th episode, which we run live every Tuesday in the evening from Asian Institute of Gastroenterology, Hyderabad. We have done with many experts world over who have faced and dealt with COVID-19 pandemic in their place of work. Today we are lucky to have one other expert from Saudi. We have my friend Professor Majid Almadi, who is the president of Saudi Association of Gastroenterology. Thank you, Majid, for joining us, and it's welcome to the webinar. And we would look forward to hearing from you your experiences of COVID pandemic, which has made the world upside down. Before we go further, may I request my co-chair, my friend Dr. Jahangeer Basha, who would introduce formally Dr. Majid, and then we can take on the lecture.
Good evening, Dr. Majid Almadi. Majid Almadi is Associate Professor of Medicine, Gastroenterologist in King Saud University, Riyadh. He is the Vice Dean of Postgraduate Studies and Research Director of Academic Affairs, and he is also the Program Director of Therapeutic Endoscopy in King Saud University, Riyadh. Currently, he is the President of Saudi Gastroenterology Association. Welcome, Dr. Majid Almadi. Thank you for accepting our invitation. Over to you.
Thank you very much for the kind introduction and for having me during this webinar. And hopefully you're going to have something that's entertaining during this upcoming 20 minutes. We'll share with you our experience in Saudi Arabia and how the pandemic has affected our healthcare services in general, and at the same time how we see things going forward. So definitely this pandemic has been unique in multiple aspects. It has affected people across the globe, across borders, across industries and healthcare facilities. And it's been a huge debate between politicians, economists, and healthcare workers at the same time. This is not unique. We've been through a few epidemics over time, and you can see over the years that just over the last 2 decades, we've seen a few economic impacts from a few epidemics. The SARS epidemic that hit mostly Canada and Hong Kong, H5N1, H1N1, Ebola in West Africa. And what's interesting is that for Saudi Arabia and maybe South Korea, we had experience with the MERS-CoV in 2015.
Majid, can you put your screen, the slide on the full screen?
Oh, okay. Let me see this. How?
Thank you.
Okay, let me come out here and one second. Sorry.
So we are still on the first slide.
Yeah.
On the slideshow, if you can just move in that will make things better.
Yeah, I'll try to do it from Zoom here. I'll end the, okay. Let me just share this thing. I'll share the whole desktop.
Yeah, thank you. Now we have it.
Better?
We got the first slide now.
Okay, perfect. Okay, so this was the slide I was talking about. Let me put it on. Okay. So is that better, Sundeep?
Yes.
Okay, perfect. So what we were talking about is the first SARS epidemic, the H5N1, H1N1, Ebola, and the MERS was something that Saudi Arabia and Hong Kong were affected by 2015, and somewhat it's endemic in Saudi Arabia, MERS. It hasn't really went away. It waxes and wanes every now and then. Now, the CDC, the US CDC, did anticipate a epidemic. They had the 2004, 9, and 14 epidemics, and they were expecting something around 2018. They were off by 1 year. Maybe they didn't expect
Can you move the slide forward? It's still stuck on the first slide.
Really? Okay. Let me see this. Stop share.
Maybe you can reshare again, I think, then you...
Yeah, I'll just reshare the whole thing again. Share. Is that better?
Yes, yes, now it's better.
It's moving?
Yeah, now
Okay,
it's moving, yes.
Okay. So 2018, they were expecting a epidemic, but I'm sure they didn't expect something that was of this magnitude, and they were off by 1 year. So I think what people, when they approach problems, you have either a problem that's where you have somewhat of a clear future, and to the degree when it's ambiguous, it becomes more problematic. And again, when you have ambiguity with your goals, when you tackle a problem, do you really want to save the economy or save lives, public health interests, political positions? When those are very obscure, not very clear, I think what describes this pandemic is very well that this is a really wild mess when you talk about outcomes. And this is the cover for the New Yorker, and it tells you when healthcare policies come out of the White House, that it's really a mess. This is a map of Saudi Arabia, and it was updated till yesterday about the cases of COVID-19 within the country. And these are cumulative cases. You can see it's mostly centralized on the western region of the country, as well as the central and somewhat of the eastern region. These are the graphs. Looking at the population of 34 million, that's the baseline of Saudi Arabia population. About 10 million are expats, about 1/3. But we hit per day about 5,000 cases, our peak. That was a few days ago. Now we're hovering a bit north of 3,500 cases a day. And if you look at deaths, daily deaths, we peaked around 50 deaths per day. And we're hovering around 42, 48 every now and then over the last week. Looking at the trend is going up, but the magnitude, looking at the population of 34 million, it's pretty small. So we don't think that we're affected to a great degree with the pandemic. Cumulative cases since the beginning of the pandemic picked up in mid-March, and we hit about 160,000 cases. About 55 are active currently, and the rest have already recovered. So I'll walk you through timelines of what happened in the country, and that affected how GI practice is done and how clinical health care is provided in the country. So since the beginning of the pandemic, there is a royal decree that everybody would be treated, whether they would be nationals, expats, legal or illegal. Regardless, they would receive health care regardless of their legal status in the country. I think that opened up people's confidence and trust in the system. As you know, containing pandemics, you really have to gain trust of the population and cooperation. Otherwise, things can get out of hand very easily. Since the beginning of the pandemic in February 25th, travel was banned to what then was high endemic areas. After that, they closed visas for Umrah, the pilgrimage to the Holy Mosque, and tourism to the area. We had a system of having a visa on electronic visas given to certain countries, so you don't have to apply properly. You just go on a website, put in your information, pay a fee, and you get a visa electronically. That was suspended on February 27th. And later on March, the first case of COVID in the country was documented. It was from a national who came from Iran. And since then, the eastern province of Saudi Arabia had been an active pocket, then the whole country started having cases. March 8th, school was suspended. So homeschooling started, and it was based on electronic platforms. And even entries to universities were delivered via distance on electronic platforms. Borders were closed on March 8th, so nobody was traveling in and out. That's all stopped, apart from goods and commercial trucks. Work in public areas stopped on March 16th, so people started working from home, which is pretty early compared to other countries. And prayers and mosques and holy places were stopped. So even going to a mosque was stopped throughout the whole country. That was March 17th. And then a curfew started for 21 days on March 23rd. And since then, it's been gradually lifted. And 3 days ago, the curfew was lifted completely, so people can go out and in. But there were some social distancing measures that were put in the country and reinforced by fees. Now going back to the gastroenterology practice and how that affected. Looking at the burden of disease in the country, you can see that gastroenterology disorders do have a significant burden of disease as a whole per quality of life years spent in the country. If you add on its neoplasms, that's a significant proportion. And the most common cancer in Saudi males is colon cancer, and the third commonest cancer in females is colon cancer. So there is a significant burden of GI disorders, and services do need to continue to maintain those issues. Given these challenges, the Saudi Gastroenterology Association had a few studies going on from its members, and there was a statement paper on how to manage endoscopy services. Although it was not unique, it was a conglomeration of what other societies and guidelines have put forth, and we put it all together in the context of the country, and we adopted what works for us. These mostly looked into aspects of personal protective equipment, which should be used, endoscopy unit flows and how patients should be segregated and separated. It looked at how teams would be managed, so manpower within the unit. And I was talking to Sundeep before air just a minute ago that a lot of hospitals have learned from the previous MERS epidemic what can go wrong. And there were a few outbreaks within endoscopy units in the country. And when there's an outbreak, unfortunately, the whole unit goes out of service for 14 days for quarantine. Even when they have a negative swab, they're still quarantined for 14 days. So a lot of units in the country have adopted a 2 to 3 team approach, where a complete team comes in for 2 weeks, then takes off for 2 weeks, then the other team comes in. And if for any reason an outbreak happens, that team gets pulled off and another team gets put in. Also, the statement took into consideration of reprocessing scopes and looking at procedures and how to schedule them, whether to postpone them. And as we were going up the incidence rate in the country, all elective procedures, including screening and surveillance, were stopped. Diagnostic studies were suspended if there was no high-risk features. Only emergency services were provided, or urgent cases based on a case-by-case basis. So depending on the consultant or the team on call, they would review the indications for the procedures and go ahead with them based on the indication, whether a delay in the endoscopy procedure would harm the patient or not. We also looked into issues of looking at leadership, coordination, transparency within the healthcare institution and how to communicate with people. We do have, at least in our institution, a weekly, almost weekly memo from the CEO and the CMO about the number of cases in hospital, the number of outbreaks within the institution, and the community outbreak and the load that the hospital is taking care of. Supply chains have been an issue for PPE acquisition, and that's also limited the number of procedures that we do based on the protective equipment we have at hand. And at the same time, it limited our use of endoscopy surface based on testing. And that's going to be clear in the next few slides. Also, there are factors that we spoke about in the initial part of the talk. External factors looking at curfews. So if there's a curfew, patients can't come in for their procedures anyway. The same thing goes for policies and procedures in the government, healthcare institutions. If you look at the, let's say, the test capacity, at the beginning, people had limited access to testing. So it was only done in a central lab in the country. So you had to gather the sample, send it to a central lab. The turnaround time was about 5 to 7 days. So it took a long time till you get a positive result. That picked up with the supply chain improving. And we started having even drive-through testing for COVID-19. That picked up the case rate pickup, but also the turnaround time was very fast. It took less than In some institutions, it takes about 6 hours to 8 hours, and it gets your test results. With the curfew, people did have problems with access to the healthcare services, so the government rolled out an electronic system for people to get access. So you would have a registered through your national ID, and if you had a red permit, you can't leave. A green permit, you can move around for whatever reasons it is, whether to a healthcare appointment or essential services. And people with a orange color permit, those are people who have been found to be infected and were put on home isolation, so they can't really mobilize around. Another application was taking telehealth to another level. So people could consult healthcare professionals through electronic applications, through physicians in there. At the same time, people who are on curfew would feed in their data on a daily basis if they had fever, shortness of breath. And if there are any alarm symptoms through the patient's feed into the software about symptoms, he would be recalled and admitted to hospital. Otherwise, people who are asymptomatic or very minimal symptoms, they would stay in home curfew. Those are all electronic solutions that came out after a while. Also, people were hesitant attending their clinics, so we started sending people their medications at home, whether they be biologics, antivirals, whatever they needed. They would be sent to people at home without them coming into hospital. A lot of our healthcare services shifted to telecommunications and telehealth. So we would constantly do our clinics at a distance. If a patient we thought deemed the need to come to hospital, we would just get him in as soon as we can. One of the issues with, and we were discussing with Sundeep about resuming our services, there was a national plan about surge capacity activation levels. And depending on the capacity of the ICUs in each city, the level would be moving from green, which is business as usual, you wouldn't have any problems, you can resume your services, up to a level 5 when you really need field hospitals to open up. And depending on where you are on this curve of infection and hospital occupancy of beds, you would open elective services and surgeries for the public. Otherwise, you would only go into emergency mode. Currently in Saudi Arabia, we're hovering around level 3 and 4. So our hospital capacities for elective admissions are less than 25%. And we only do essential services and emergency procedures at this point of time. As you saw at the beginning of the presentation, our curves were going up. So we really opted not to open elective procedures at this time. Not only endoscopy services were affected, but even transplant services. And this is one of the hospitals in our country that does a lot of organ transplants, King Faisal Specialist Hospital. They do have 3 branches across the country. So we have, last year they did about 186 liver transplants. The majority of liver transplants in Saudi Arabia are live donor transplants. So those have been suspended. At the same time, we do have pancreatic and small bowel transplants, but to a much smaller degree than liver. Saudi Arabia at one point was very endemic with hepatitis B, and there was some hepatitis C, but it's much less now with the national vaccination program, but we're still taking care of the cohorts that were infected in the past. This effect is not going to be short-lived. As we know, when we open up services, we're going to need to do workups for the people who had surgeries delayed, whether for non-so-urgent cancer cases. So even transplants are going to be affected, and donor availability and workup is going to be delayed. As you know, there's going to be a waiting list for operating theater. This is not unique. I'm sure this graph even shows that in India, these are not elective surgeries. These are cancer surgery canceled throughout the world, and that's early in the pandemic. I'm sure it's even worse now. We started looking into the, so that was from a healthcare system, and we think we're doing a good job. But we want to see what your patients are feeling. Well, what are they suffering? So we did a small study looking at the, using an instrument called the IBD disc. It looks at multiple axes of health. ranging from abdominal pain, bowel movements, social interactions, emotions, body image, and sexual function and joint pain. It takes the spectrum from 0 to 10. And you have a figure at the end that looks like this. So the smaller your circle, the better off our patients are. The larger the circle, the worse off the patients are. And depending on the area, those are targets are less. So we did a study looking at the effect of COVID. So we were using this tool even before the pandemic. And we looked at it after the initiation of the pandemic. Was there really any change in the healthcare status of our patients with IBD? Now, be it this was a very small study because we never knew that there was a pandemic coming anyway, and our services went to a halt, but we didn't find any really difference in inflammatory bowel disease patients and their affection with the pandemic. But another group did a survey of 1,000 people with inflammatory bowel disease in the kingdom through social platforms. And interestingly enough, about half of the population of IBD had the symptoms of anxiety, and borderline symptoms of depression and anxiety was about another like 1/3. Also, we did capture a few cases that self-reported that were affected by COVID. So these were mostly on 5-ASA, not really immunomodulators. Some were on, only like 2 were on biologics, and none of them had any comorbidities or complications from COVID itself. But again, this is a self-reported questionnaire that does have its biases. Of interest in that study, and honestly it gives you an insight of how healthcare for our GI patients is, 1/3 of the patients stopped their medication or delayed their medication. And only 1/3 had access to their physicians. So it tells you even with all these new solutions, we still can't cover the healthcare needs of our patients. Even with all these innovative type of implementation. So what we did even as a society and a healthcare system, we started educating people. So we launched a IBD guide website, which is in Arabic and should help not even people in Saudi Arabia, but around the Arabic world who speak Arabic. Looking at the IBD crisis, the crisis of COVID and how to manage your disease during that period and healthcare professionals. And it's worked very well. Now, that gives us a briefing of what happened, and it's going to happen again. And it's very clear that this is not going to be the end of epidemics or pandemics. And if anything, we really should learn from our previous experiences and prepare for the next time and have systems that are ready for the upcoming healthcare crises that might happen down the road. We're hopeful that things were going to go well. For the last 3-4 days, our ICU capacities have plateaued, so there's no increase in need, and hopefully we're going to get through this together. It's been an anxious time for all of us. I'm sure our loved ones and families and patients are a bit scared of what's happening and what's the future going to look like. But I think countries like Hong Kong, Italy, gives us hope, and Singapore and New Zealand gives us hope of this could have a positive turn, and we can all learn from each other. So that's pretty much it, and thank you very much for having me.
Thank you, Majid, for sharing your experience, and very nice talk, and how the Saudi government and Saudi people coped up with the scenario, and how the gastroenterology practices changed. Jahangeer, any questions or comments before we let the questions from the audience?
So Dr. Majid, that was an excellent talk, and you have given the complete overview of all the problems and the situations that are facing with the current pandemic. So coming to the endoscopy practice as a gastroenterologist perspective, what is the current status of the endoscopy practices in Saudi? So are you restarted the procedures, or still some restrictions or the continuing of the procedures, are only emergencies are tackling now? So can you give some idea about how your country is facing about this?
Perfect. That's an excellent question, and honestly, it's going to depend on the each city in the country and how it's affected. The city I'm in is one of the highest cities with the incidence rate, but also has the largest, one of the largest populations. Currently, we're doing only emergency procedures. Let's say GI bleed, cholangitis, CVD stones, colon cancer with obstruction. Screening surveillance has stopped. When we need to use procedures or evaluate patients, when we have options that are non-invasive, we use those. Let's say for dysphagia, we can go for a barium swallow prior to going for a gastroscopy, although it's a primitive way to evaluate, and depending on the risk profile of patients. But we've been also stuck in very unique positions. So let's say people with hilar biliary tumors. So you're stuck with endoscopic interventions or PTC, and you don't have OR capacities or ICU capacities to take these patients when they're going to need surgery. The same thing goes for we have a lot of gallstone disease. So we see tons of patients with common bile duct stones or gallstone pancreatitis. We perform an ERCP, put a stent, clear the duct, keep a stent because they're not going to have their cholecystectomies for a while, and they keep on coming with stent exchanges. So although you think that we're not doing a lot of volume, we still have our constant volume that we wouldn't do on a regular basis. So patients with stones would go for a cholecystectomy and that would be it. But we're seeing these patients again and again just to maintain them because other services are disrupted other than endoscopy itself. So that's we also take into consideration when we're looking at these patients is the intervention really going to make a difference if you don't have a definite plan for this patient and you're still stuck in a twilight zone between you need surgery, you need chemotherapy, you need other services and interventions that have been suspended. So it's very awkward, but it's becoming the new norm for us now that we deal with these semi-urgent patients on a regular basis.
Thank you. So do you screen the patients before taking the patients for the procedures, even emergency procedures? Do you have that facility of getting a RT-PCR, some kind of serology test to see whether they are having any infection before the procedure?
Excellent question, and we've been on a task force with multiple people around the world, and there was a debate that should we really test everybody or not. That really depends on the capacity of testing in the institution and the country. We do have the capacity. After the initial period, we did not. So currently, we do test every person before, but at the same time, this test isn't perfect. And we did have an outbreak in one of our hospitals that the patient tested negative, developed a fever on the second day of admission, and she turned around positive, and the whole team was put on home isolation. So we do test people, but at the same time, it really doesn't impact our practice because we're going to deal with them as if they were positive. So emergency cases, we do them with full gear protection. Elective cases, we test them definitely that need urgent care but not emergent. Emergency cases, we just do it with full protective gear as if it were a positive case.
So what's the usual turnaround time for RT-PCR before you contemplate an endoscopic procedure?
Our hospital has a turnaround time of 8 hours.
Okay.
I know the MOH has something around 2 days, so it's not perfect. But because they deal with a lot of primary and secondary care facilities, it's not only our hospital is only a university hospital, so it's closed on a small population. So we have that luxury. But the MOH has a much higher load. But the turnaround times have improved dramatically. Initially, in the beginning of the outbreak, it was something around 5 to 7 days.
Oh.
Currently, it's around 2 days maximum. That's what I know now. They're even doing drive-thrus, and you get your results in 24 hours.
So a curious question is, what about patients who are in dire emergency, somebody who has a bleed and say varicose bleed who needs an emergency endoscopy? What's the policy there now?
We do a procedure as if it were not a COVID period. We deal with them as if it were a regular period. We just go on with our full gear equipment. A lot of guys with beards like me take on the full PAPR thing. Others, no, they use face shields and overhauls, and they do the procedure as if the patient was positive, but we don't delay any emergency procedures for the COVID status at all. We do it as if it were not a COVID period.
Thank you. Yeah, that's a very difficult decision to be made. We either treat everybody like a COVID patient and act accordingly, and those who are kind of stable or can sustain their problem for a day or so that till you get the report and act accordingly. Yeah. Majid, you being an excellent epidemiologist, how do you think the previous experience in Saudi of MERS, Middle East Respiratory Syndrome, has helped Saudi this time to tackle the current epidemic?
I think on a system level, I think the country was very wise. You can see that at the beginning of the slides, I said the whole country went into lockdown very fast. Just because they've seen the magnitude of the effect of the MERS-CoV from the previous epidemic. And we did have a lot of economic losses during that period. And then travel was an issue for us, and then livestock were affected, the economic status and health status of our population was affected. MERS has a much higher fatality rate compared to COVID-19. So they realized the magnitude and the seriousness of the issue, so they went into full lockdown very fast. Even health institutes, the MERS, we had an issue with health-related outbreaks. So although there were community cases, but usually what happened during the MERS outbreak was that healthcare facilities became foci of infection. So healthcare practitioners were an issue, and we went through extensive training for healthcare professionals at the beginning of this crisis with doffing processes. We entered protocols of how to manage patients, how to isolate patients. So we did have some muscles to flex, so there was some muscle memory when this came back again. But again, honestly, whatever you anticipated before, the magnitude of this pandemic was much higher than anybody would have imagined during the beginning of the outbreak. Maybe we had a bit of a head start, but nobody could imagine how this thing would evolve over time.
And even the public would have accepted the social distancing and hand hygiene, because that's sometimes difficult, as seen world over, that many people, the general population is not aware at what precautions they have to take, and they have to take it for a very long time. It may be months or maybe years together. Thank you.
Very true. And honestly, even the public media and information that was very heavy in educating the public. And although, yes, education is part of it, but there were hefty fines for anybody who broke the law. So I think there was part of legislation, and people do value their money. So there were both aspects working at the same time.
Okay.
What is the policy over there about the prophylaxis with hydroxychloroquine? Are you giving any hydroxychloroquine prophylaxis, especially for the healthcare workers?
Yeah. This is a major debate in the country. We had a debate on multiple levels. The MOH has its own protocol for dealing with people with COVID, and at the beginning they involved in the Solidarity trial, the one from the WHO, looking at multiple aspects of arms of remdesivir, standards of care, hydroxychloroquine, and anti-IL-6 medications. So that was a nationwide trial that a lot of centers went into. Hydroxychloroquine prophylaxis, at least in our institution, we didn't implement it. I know a lot of healthcare facilities did not. Hydroxychloroquine therapy is practiced in the MOH. In our university hospital, it's only done on a research protocol based, but it's not given as standard of care. But it's only on a research-based protocol, but it's not given as standard of care.
One more recent drug is remdesivir. Do you have any experience? It's available in your country. Anybody using that? Because we may be getting in a week, maybe 10 days. So we just wanted to hear from you about any experience.
India is a huge pharmacological hub, so we have the luxury of the industry being at home. We don't have remdesivir in the country, honestly, till now. We tried to purchase it on a institution basis. It's been cleared by the Saudi FDA, but it hasn't been arrived, at least in multiple institutes in the country. No, we don't have it for now.
So if you put your epidemiologist hat now, leave the gastroenterologist aside, how do you foresee the pandemic situation, say in 3 months from now, 6 months from now, in Saudi and world over?
It's really difficult.
I know it's a difficult question, but
there are multiple speculations, and you feel like a forecaster of weather. You can get it wrong or right. Infectious epidemiology is a specific field in epidemiology, and they have their own models and predictions and aspects. But going through history, honestly, looking at the Spanish flu, although there are multiple differences between it and the current pandemic, and also looking at the previous SARS epidemic that affected Hong Kong a lot and Canada. A lot of people went into the vaccine industry hoping to get something out fast, and it disappeared on its own. Whether it goes into a cycle or not, really nobody knows. We've seen in Italy and in other countries, it hit a peak and fell down on its own with public interventions. Whether it's going to be a chronic circulating type of virus, that's a possibility. Our MERS virus never went away. It's still around. It plateaus and comes back and forth, but it's still around. I think this is going to be something like a seasonal flu. It's going to take a cycle around. We took a hit initially. Whether they are going to be a second wave of the pandemic or not, hopefully not. But I think the way forward is going to be a vaccine. It's going to be something like a circulating annual seasonal flu. It's going to be like something in the population. The amount of infectivity and it's circulating through the globe in countries, it's going to be difficult to clear through a single cycle.
okay.
Since you are an epidemiologist, one more related question, not about the second wave. What is the risk of reinfection? Because some reports are coming that it is a fact or just
False
to be
report.
neglected like that. Your
Yeah,
comment on that.
it's very, very interesting how we learn with time. So Sweden thought that they would get this off with the herd immunity. And I think studies like a week ago found that only 6% of the population have antibodies, which tells you this herd immunity approach isn't working very well. Also, the mortalities in Sweden per 1,000 population is high. The economic impact, although less, but there's still a hit to the economy, whether you like it or not. Some people value their lives and they're not going to go out and purchase and go to restaurants, and the economy isn't going to pick through. And your economy isn't isolated from the world. So if the world doesn't pick up, your economy is not going to pick up. So going back to the issue of reinfection, it seems these coronaviruses don't have a long-term immunity. Even when you get immunity with the previous infection, it's usually 6 to 8 months, then it wanes off. Whether this COVID epidemic plays the same way or not is to be seen, but I'm not really optimistic about having a long-term antibody that could protect you from a second infection. You might have it as a hepatitis B thing. You have an antibody, it drops down, but you just need a small booster and it helps you regain immunity. That's a possibility and a theory to be explored. But I don't think it's going to be like a varicella zoster thing. When you get it once, you're not going to get it throughout your life. It seems not to be behaving that way.
Okay, Majid, thank you very much for sharing your experience of Saudi and in general of how the virus is going to behave. There's so many unknowns in this pandemic. The experts all over the world are still groping in, we can call it dark, I don't know. The vaccine is far away. The right medicine is still not sure which one works. It's only the preventive efforts which are only making a difference in bringing the infectivity rate down. We just hope the herd immunity, whenever it reaches that threshold level, will prevent the further spread of virus. I think with that, we'll wind up, and thank you once again for sharing experience. Thank you, Majid, very much.
Thank you.
Thank you very much for having me, and keep safe, all of you. Thank you, Sundeep. Thank you, Basha.
Bye.
Thank you, bye.